Everything's all right. You have your 20 minutes. Go ahead.
Right. So I'm not going into that carotid anatomy of mine. Otherwise, Vlad is going to have a seizure because he's heard it so many times. Now, this is an ACOM aneurysm. I just wanted to show you a few things that if you don't have your 3D imagination, what can go wrong? That's exactly what I wanted to show you. So you're opening. This is a pretty bad bleed. It's done 5 years before. You can see we opened a 3 or 4 centimeter incision, and we are just identifying the carotid here. And since you saw the scan, you probably know that the aneurysm is between the 2 optic nerves. So if I go try and dissect the A1, it's going to be a long, after you saw the scan, you must probably know that the A1 is curved backwards like that. So here I've exposed the aneurysm. You can see the aneurysm starting to get exposed. So here our proximal control is ICA. And I must know where exactly, because I'm exposing the aneurysm first. I'm not exposing anything else first. I'm exposing the aneurysm first. So we don't have, our proximal control is just IC, and very soon you will even see the rupture point. So I'm going to show you even the rupture point on this aneurysm. And you can see that clot there, the blackish clot will be very clear once I take off the arachnoid. So I am right now dissecting the fundus of that aneurysm. Taking the arachnoid off the fundus of the, and you can see the blackish area there, which, sorry for the poor quality of this. It was about 5 years back. So this is the aneurysm rupture point. This is the rupture point. You can clearly see the rupture point there, and that's the neck. That's the neck. And now, this is where you expect this aneurysm to rupture. And so I'm not exposed. I have exposed the rupture point. I have exposed aneurysm. I have not exposed laterally. And now I'm trying to get the neck here. So you got the optic nerve there. You got the carotid there. A1 is somewhere behind there. So the rupture point is right there. And I'm going to see and get the neck so that I can put the clip on. So here, your 3D anatomy should be very clear. You should know where the ACOM is. You should know where the A1 is. You should know where the A2 is in the interhemispheric fissure. This is very important because here the only thing exposed is the aneurysm and the rupture point. And that is when the rupture happened. So it is not from the rupture point before, it's from the neck. So this is a little rather difficult proposition. So here, you can see we put a clip on the IC, and now I know that the rupture point is somewhere near the neck, not where it had ruptured earlier. So I was trying to mobilize that neck from the optic nerve, and that's exactly when it ruptured. So I am trying to find out where is the rupture point. It was the rupture happened at 14:38. We have about 5 minutes safe. So I've now outlined the entire aneurysm there. That is the aneurysm. You can see the A2 going there, and there is the neck from where it is ruptured. So I am going ahead and I'm going to put the clip on right now. So IC clip really doesn't help you to clip an ACOM. In fact, one A1 clip also doesn't help. You have to put clips on both A1. But see what's happening right now. So it's flooding the field. So I'm taking the patty off, going for a direct suction there, and then I've identified this is the tear in the neck. So I'm going to incorporate that gently, bring my clip up till I incorporated the tear completely, gently, and there is the clip. And now you can see all the vessels, A1, A2, ACOM, and the aneurysm completely clipped. So this is another case where this aneurysm, this PCOM was stuck to the tent. You retract this PCOM, it's going to rupture. It's stuck to the tent and it's riding over the third nerve. So you can see the IC, the PCOM is going there, it's below the tent, that's a tent there. So I have to excise this tent. So I have to first bipolar the tent with very low current because I'm right over the aneurysm. So I'm going to bipolar this tent and then I'm going to use a 15 blade right over the aneurysm. So in fact, a blade is what is best. So I'm cutting it so that the curved point of the aneurysm is actually beyond. So the curving point is beyond. So I'm close to the aneurysm, but I'm not cutting over it. So now bipolaring and cutting the tent. See how densely it is stuck to this. So slowly I'm able to gently mobilize the tent and remove the tent away from. It's like removing a tumor, and now I'm going to separate it from the third nerve. So you can see that's a third nerve there, down there, that's a third nerve. And so I'm going to separate it from the third nerve. So the PCOM is going that way. I have separated this aneurysm now. So I want to see what's the shape of this aneurysm. The third nerve is completely free there. Generally, this is with no proximal control right now, no proximal control. So we are slowly taking it away from the third nerve so that the patient's third nerve palsy, partial third nerve palsy improves. And this is a ruptured aneurysm. So that's a bit of a tent stuck to the fundus there. So I'm getting a measure of this aneurysm, and right now, through that, I know where the PCOM is, and I go for the clip. That is the clip. And that's the end of it. Now, ICG, now that's a paraclinoid aneurysm. In fact, we are going to do one tomorrow. So that is the clinoid process, and you can see that the aneurysm is right there. The aneurysm is right there, okay, underneath this clinoid process. So I'm going to remove this clinoid process extradurally, and you will see how close we are to the aneurysm. And that's what I wanted to show you. So when you're doing next, so you can see the aneurysm there. So you're going to drill the clinoid process right now. After I have done the early transcavernous dissection, so I have opened up the clinoid process right now. Orbitomeningeal band has been cut, and you can see the dissection has been done up to V2. So the clinoid process is right opened up there, and now you have. So we have to we have to drill under complete irrigation. So that's what I'm doing right now. Gently, and then now cutting furthermore to open up. This is axial unlocking. I call it axial unlocking. So once you do the axial unlocking, you can furthermore mobilize the clinoid there, and then you can drill it further, thin it out. Here, you obviously cannot pull out the clinoid extradurally because that may be a bit adventurous. So you are thinning down the clinoid to literally eggshelling the clinoid. And you must know that you have the optic nerve there. That's the optic nerve. That part where my drill is right now. So that's the optic nerve roof. It's already been de-roofed. And it's only the clinoid and the optic strut which is remaining. And the aneurysm is right underneath you. Right underneath. I'll show you the discoloration of the dura. Now I'm drilling, eggshelling it off and removing the clinoid as much. So now we're going further. Now we'll have to use a small drill because the space to the optic strut is not very good. So now you can see the optic nerve very clearly that this is the optic nerve. That is the optic nerve, and this is the strut. And the aneurysm is just beneath the optic nerve. So when you're going to drill the strut, you are very close to the aneurysm. Now I mobilize this a bit, and you can see that is the optic nerve. This is on the very end, and I'm going to drill the remainder of the clinoid, and you can see the discoloration here. Please see the discoloration here. That is aneurysm. That's underneath the dura. So under very high zoom, we go ahead and drill further and mobilize this, and you can see now the aneurysm very clearly underneath the dura there. That's optic nerve. And now I'm using a 1 millimeter drill to drill the strut off. Very gentle paint-like usage of the drill and you must be very careful here because this is a 1 millimeter drill. Is literally like a needle. It can pass through, and you shouldn't even think about that possibility because that can kill you here. So here we are completely thinning down. That's the aneurysm there. That is optic nerve there, and you are going ahead and drilling out all the remainder of that clinoid and strut, and that is your aneurysm. So now when you're going to open your dura, things are much more easier for you. Drill out everything, and then after that mobilize. Irrigation at each point. Drilling the rest of the optic strut there. So you can see that's the optic nerve there. And under very high magnification, drilling off all that bone gently. And all the while you can see that the aneurysm is lurking there underneath the dura. Mobilizing. Drilling. Taking out everything now. And you can see the aneurysm there again. There's a large one. You can see the discoloration of the aneurysm there. Removing all that bone clearly. Now opening the dura. And once you open the dura, you just have to cut the falciform ligament. You can see you cut the falciform ligament, and there you have the aneurysm. The clinoid is not there anymore. Clinoid, not the clinoid, not the optic strut, nothing is there. So it's rather not very difficult to cut this falciform and get excellent control of this aneurysm. So you cut the falciform back into this dura, and then you have good control now. So you are going to mobilize that dura this way, cut the proximal ring, the remainder of the distal ring, cut the remainder of the distal ring. And then now you have the aneurysm. So that is the C3 carotid going down. You have to be parallel to the C3 carotid. That's very important because otherwise, if you cross clip, you can clip the carotid off. This is very important. So you have to be parallel. So your clip blades are parallel to this. You can see the C3 carotid going down into the cavernous sinus because you cut the rings now and you are going parallel to the C3 carotid. You can see the C3 carotid dipping down there, and you put your clip. And you can see the C3 carotid going down, and that is a clipped aneurysm. So that's optic nerve, that's a clipped aneurysm. That's a basilar, that's a backward pointing basilar. So we are going to do the same dissection, take out the clinoid, and once after that we can open the optic nerve is there, and the carotid is here, and you're going to see the third nerve there. And so I'm going lateral to, that's the carotid, that's a PCOM. The PCOM leads to the P1 segment, so you know, and the anatomy, that's a third nerve. And now I'm going in between the optic and the carotid at very high zooms, developing a plane between the optic and the carotid. Also doing a proximal Sylvian dissection so that I get more space. You must cut all the arachnoid because in this field, because this is what gives you excellent space. You can talk about a lot of different classification, but I don't like classification. Whatever arachnoid is in my way, I take it. So now that's the third nerve. So that's the carotid, the PCOM, very clearly seen. And that's the A1 there, that's the optic nerve. Membrane of Lilliquist is being cut at a very high zoom. And you can see the basilar there. The thing is, now you have to find the contralateral third nerve. That is what helps you to identify which is the P1 and which is the superior cerebellar. So you can see the third nerve there. The white part is the third nerve. So anything above the third nerve is P1. So that is P1, this is P1. And this should be the aneurysm. It's backward pointing, you see, that's the thing. So whenever you have a backward pointing aneurysm, it's not a great thing to do operate on. So it's backward pointing. So you are taking out, you are making a plane between the P1 and that's the aneurysm. So once you get backward and one side pointing to this side, so that's the aneurysm neck. Once you get a good plane on the aneurysm neck, you are ready to go ahead and clip this. So you have P1, you have basilar, contralateral P1, that's the aneurysm. We're going through the opticocarotid window. So we go ahead through the opticocarotid window, and then you go ahead and keep on opening and closing the clip, gently opening, and this will improve. This will increase your space. So your 3D perception in this depth is difficult. You know, your clip perception in this kind of depth through this window is, although the microscope gives excellent 3D view, but at this magnification, your 3D depth is a bit off. So that
2 minutes, Iype.
Yeah, I'm done, Vlad. It's less than 1 minute for me now. I'm done. So that's a clip. It's the aneurysm is clipped, and that's it. Thank you. Thank you very much.
Thank you, Iype.